So hello all there, I will be talking about brain death determination in India. Uh, Initially, there is some problem with this hardware. So initially mankind thought the patient, a person is, initially the mankind thought that a person is dead when he stops breathing, he is unresponsive, he is unconscious. Later on, in the 16th century, the cardiovascular system was discovered. Uh, People started uh, uh, palpating the pulse, and they said that a person is dead when his respiration and heartbeat both stops. However, this concept was challenged in 1950s when the concept of brain death evolved. This all started in Massachusetts General Hospital in Boston. Uh, there were some patients who were deeply comatose, who were on mechanical ventilation. They had all their reflexes absent, and and also when the physicians did an EEG on them, it showed a flat line, that is isoelectric activity. So when these patients were followed for weeks or months, nobody regained consciousness. Also, uh, they didn't had any spontaneous respiration of their own. So the physicians in the Massachusetts General Hospital proposed a Harvard criteria for determining irreversible coma or brain death as it is known today. So they said there are four criteria by which we can determine that a patient is brain dead. This was unreceptibility, receptivity and unresponsivity, no movements or breathing, no reflexes, and a flat or isoelectric EEG. So, based on this Harvard criteria, the US government passed the Uniform Determination of Death Act in 1981. This act was unique. This stated that a patient is dead. A person is dead not only when his respiration and heartbeat stops, but he can also be declared dead if his heartbeat is or respiration is continuing. He is not dead by physiological criteria. However, there is irreversible cessation of all functions of the entire brain, including the brainstem. So, American Academy of Neurology gave guidelines for determination of brain death in 1995, and these were revised in 2010, and this time these were evidence based. So, when you see a patient who is deeply comatose, his reflexes are absent, he is not breathing spontaneously, he is on mechanical ventilator, and you suspect brain death, the next step is to find out why this patient is in this condition. What is the cause of his deep coma? Before we know the cause, we cannot go for brain death testing. The most common causes are traumatic brain injury, which is the number one cause worldwide, aneurysmal subarachnoid hemorrhage, intracerebral hemorrhage, large ischemic strokes like large MCS stroke, which can cause herniation, post CPR hypoxic injury of the brain, or acute liver failure. Why should we know the cause? So, if a patient comes to your hospital in a gasping state, unconscious, he is intubated in the casualty, history is not known, what has happened to him, some unknown people have brought him, uh, he is intubated, mechanically ventilated in casualty, shifted to ICU. By the time he is shifted to ICU, uh, he's deeply comatose, his spontaneous respiration is gone, all his brainstem reflexes are absent. So, can you declare him brain dead directly without going for any further investigation or asking for history? No. The cause is no, because you must know the what is the cause of his deep coma before going for brainstem testing, or rather I would say declaring him brain dead. This is because there might be some causes of this deep coma which are reversible. So in that case we cannot declare him brain dead, like he might have consumed large amount of sedatives or neurotoxic substances which have led to this deep coma and absent reflexes, but this condition is reversible. So the most common test which we do to determine the cause of deep coma is the neuroimaging. Though history is a major part, neuroimaging also plays an important role. So most often we see such kind of cities in these patients. Either we see diffuse cerebral edema, as in this case this was post CPR patient and had diffuse cerebral edema and was declared brain dead, or we see a large intracerebral or extraaxial hemorrhage. We second step is we also need to exclude certain things which might be confounding the testing of brain death. These conditions may not by themselves cause this severe coma with absent reflexes. However, they can confound the brain death testing. These include severe hypotension, drug effects, severe endocrine disturbances like severe hypothyroidism, adrenal insufficiency, severe electrolytes and acid base disturbances, effect of alcohol, effect of neuromuscular blocking drugs, and hypothermia. However, if the cause of coma is not apparent despite history and neuroimaging, what should we do? Some of the causes of deep coma or brain death per se, which may not be apparent with history or neuroimaging, are presumed hypoxic brain injury, which has occurred 2-3 days back, and cerebral edema is not so evident on the CT scan of the brain. Cerebral air or fat embolism, in which also the neuroimaging might be normal, severe drug overdose, or post encephalitis. So in such situation we should continue clinical observation and investigation at least for a few hours to days to rule out any irreversible cause before we go for brainstem testing. So according to American Academy of Neurology in the US, any physician who is well versed with doing brainstem or brain dead testing can go for brain dead testing. He need not be a neurologist, neurosurgeon, anesthetist, intensivist. However, these people are preferred over other physicians. In UK, according to the uh, Association of Medical Royal Colleges, at least two doctors which are senior, that is registered for at least 5 years, and one of them is consultant, must be present to do brainstem testing. So what about India? Who can do brainstem testing in India? The only document or legal document available which defines who can do brainstem testing in India is the Transplant of Human Organ Act, which was passed in 1994. It says that brainstem testing can be done by a team of 4 medical experts, which must include: first is the head of the institute, which is generally medical superintendent. The second is a neurologist or a neurosurgeon. The third is the doctor who is in charge of the patient, the primary consultant. And the fourth is a doctor which is part of the team of brainstem testing. This team should be present and should be approved by the DGHS, by the appropriate authority, and should be present in every hospital which can do brain dead testing. And this test was amended in 2011 because of the concern that a neurologist or a neurosurgeon might not be available in every hospital which has a ventilator which can declare brain dead, and organs can be procured from them. So they said in 2011 that either a anesthetist intensivist or a surgeon physician can replace a neurologist or neurosurgeon, that is the number 2 point, if the neurologist neurosurgeon are not available in the hospital. whether we should do a single examination and declare the patient brain dead, or we should go for an another examination immediately or after a few hours. So American Academy of Neurology says only one examination is enough to declare brain dead. However, in some states of US, two examinations are mandatory. In UK, they say that two examinations are necessary. The second examination can be repeated immediately after the first examination. This has to be done to eliminate the observation bias. In India, the same act, the THO Act 1994, says that at least two tests are mandatory and the difference time period between these two tests should be at least 6 hours.